Low socioeconomic status contributes to heart disease. Low socioeconomic status is directly related to increased risk factors for heart disease due to a lack of resources, poor lifestyle habits, and economic factors. Heart disease is the leading cause of death in the United States. Overall, the U.S. spent more than $500 billion in 2010 on health problems related to heart disease and stroke. Disparities within the population affect access to medical treatment, treatment outcomes, and increased risk factors and mortality. Poor minorities receive worse care than the higher income majority population. Assessment is used to diagnose, investigate, and monitor health disparities, conditions, and illnesses in order to maintain the general welfare of the population. In order to understand the nature of disease, whether it has a chronic or infectious nature, the assessment phase is vital to implementing public health strategies in order to correct or improve the situation. Living in impoverished conditions increases negative stress. This stress, along with poor environments, are linked to heart disease. Depression, stress, and a history of attempted suicide have also been linked to increased risks. In adults younger than 40 years, depression and a history of attempted suicide are significant independent predictors of premature cardiovascular disease and ischemic heart disease mortality. Social exclusion increases exposure to negative events like hunger, food selection and quality, insufficient housing, inadequate clothing, and poor conditions surrounding the environments people work and live in. Those suffering from social deprivation have less access to positive resources like education, public events, and leisurely or recreational activities that would reduce stress. Risk factors outlined by epidemiological means are gender, heredity, age, physical inactivity, smoking, obesity, high blood pressure, high cholesterol, and nutrition. A lack of resources, like access to healthy foods, a conducive environment for physical activity, education, and affordable health care have caused increased risks for cardiovascular health in those who are impoverished. A lack of health education leads to increased behavioral and social risks for heart disease, like smoking and having a poor diet. Reduced income limits access to health care and medical treatment. More males die of heart disease than females. People aged 74 years and older have the highest number of deaths. White non-Hispanic and black non-Hispanics were the highest ethnicities to be affected by heart disease. Education level can also be linked to an increased risk to heart disease due to poor resources and inadequate health counseling. Over 65% of individuals with a GED or no high school degree report to smoke cigarettes, while less than 10% with a bachelor's degree do. Human capital is an important determinant when it comes to a person's social and economic status. Higher levels of human capital affect education, income, and the positive aspects of a person's environment. Obtaining a higher education is directly related to social and economic opportunities. These opportunities can come in the form of higher paying jobs that offer health benefits to employees. Lower education levels are associated with less income and poor living and working environments. Public health organizations are essential when it comes to identifying and solving health problems. Mortality rates have gone down in the last 5 years from heart disease and stroke, with an overall reduction of 68% between 1960 and 2009. This decline can be attributed to public health organizations educating the public on effects like smoking, as well as technological improvements in screening for cardiovascular diseases. By monitoring health and identifying risk factors, public health can implement directive actions, policies, and procedures that are designed to reduce chronic diseases. In educating areas where low socioeconomic status is prevalent, public health organizations may be able to reduce risk factors and improve heart disease. Lowering the percentage of cigarette smokers, increasing education about health risks, and improving diet and exercise in poverty-stricken areas should reduce the amount of people with heart disease in the future. Policy development is essential when it comes to planning a strategic course of action in order to improve health outcomes for the population. Many health initiatives have been implemented to reduce heart disease, both in the U.S. and internationally. The Victoria Declaration in 1992 and the Catalonia Declaration in 1998 have made incentives to coordinate public health efforts through the government and private sector while assessing what kind of resources and assets would be needed to improve or properly invest in heart health programs. General policies have increased the screening process for early detection by checking things like high blood pressure and cholesterol, which have improved the detection and recognition of heart disease and stroke. As of 2011, the U.S., Europe, and Canada have been working on a policy toolkit to reduce cardiovascular disease. This partnership between the National Forum for Heart Disease and Stroke Prevention and the Collaborative Integrative Non-Communicable Diseases Intervention Program will use this policy toolkit to increase public awareness and reduce risk factors associated with developing heart disease. Before policies can be drafted and implemented, the link between poverty and heart disease must be addressed. A California study showed that there were higher death rates caused by heart disease in the poorer Los Angeles County than in wealthier counties. The study also concluded that poorer Black communities were more likely to die from heart disease than the wealthier communities. The Global Cardiovascular Info Base showed that mortality rates from heart disease are increased in the percentage of the population living below the poverty line. Individuals in Canada living under poverty are exposed to many risk factors. Because of this, poverty is a greater predictor of heart disease than risk factors such as smoking, obesity, or stress. The Affordable Care Act has been implemented to increase the access to medical care for those who are underserved. Other government policies in the U.S. have addressed some of these risk factors by implementing nutritional assistance programs, unemployment programs, welfare, and increasing medical care. Existing policies have brought awareness to heart disease and are actively encouraging changes that are designed to reduce risk factors. Some of these existing policies are reducing the amount of trans fats in foods, labeling the food products to warn about sodium trans fats and saturated fat content, and establishing activity guidelines. Lawmakers passed a smoke-free workplace legislation which covers 55% of the United States. The Tobacco Products Regulation 21, CFR, has enacted to reduce the sale of tobacco products to adolescents. Tobacco products are used more frequently in areas of low socioeconomic status. Arnold Schwarzenegger signed a bill that requires restaurant chains with at least 20 stores statewide to post the calorie counts on menus. The Child Nutrition Act makes major changes in the food that kids consume while at school, in foster care, and in after-school programs, even requiring healthier standards in lunch programs and in vending machines. In creating more public parks in poorer neighborhoods and establishing more mandatory physical education classes in school, lower socioeconomic neighborhoods will have a safer place to exercise, and children will be taught the importance of good nutrition and fitness. If monetary incentives or tax credits for breaks are offered to farmers markets, more communities with food deserts would have access to fresh produce, reducing the need to eat low-nutrient foods. There should be stricter regulations when it comes to smoking in public buildings and public places. Smoking should be prohibited anywhere near a facility for children, like daycares. Underprivileged children have access to poor food choices, which increase risk factors. Limiting the types of foods that can be purchased with government nutritional programs to only healthy options would improve nutrition. The most important stakeholders in healthcare are the patients living in poverty, because they are the most at risk. One organization which has helped with policy development in this issue is the USDA. They are on the forefront of ensuring proper nutrition in schools and proper labeling of food in restaurants. Another organization that has helped with policy is the American Heart Association. They spearheaded the campaign in eliminating smoking indoors, refused to hold conferences where smoking is prohibited or permitted, actively campaign, sponsors research, and provides resources for heart health. Hospitals and medical clinics are involved in patient care. Many of these medical facilities reach out to communities to provide care at low cost because they are nonprofit organizations. Local farmers markets are able to supply fresh produce to communities that suffer from food deserts or have a lack of fresh fruits and vegetables, potentially alleviating many of the nutritional concerns associated with heart disease. These attributes make the selected stakeholders vital. Informing, educating, and empowering is an important step in the public health process. Empowering the population to take their health into their own hands by giving them the tools to do so will give impoverished populations power over their health. Educating and empowering younger generations to make healthier lifestyle choices like eating right, exercising, and avoiding smoking will change the next generation to improve future population health. Mobilizing community partnerships within communities creates strong support networks that will provide more people with better access to information, education, and health care. Policies give direction and purpose to research and collect data. They streamline public health actions in order to maintain and consistently improve a population's welfare. Policies address these factors by reducing smoking, increasing exercise, establishing good communication and resources, and employing health representatives in poor areas. The final essential role of public health services is assurance. Once assessments are made and policies have been implemented, officials determine if policies and programs are effective and sustainable based on results. A core function of public health is to enforce laws and regulations that protect health and ensure the safety of our population. Officials of the FDA need to see if menus have caloric information. Superintendents of schools should observe if the school is providing proper nutrition and exercise to children. Children should receive a minimum of 30 minutes of exercise per school day. Another core function of linking people Another core function is linking people to needed personal health services and assure the provision of health when it is not available. The CDC, as well as local and state health agencies, communicate information to the public via various communication methods. The information provided includes classes on nutrition and health, events, marathons, dances, support groups, and new preventative measures. These are all aimed to reduce heart disease. Assuring a competent public and personal healthcare workforce is an important core function of public health. Some methods for attaining quality personnel are performing background checks, conducting mandatory training exercises, providing skill-building classes, testing employee skills, ensuring everyone is current with their licenses, and requiring certain educational criteria. Evaluating effectiveness, accessibility, and quality of personal and population-based health services is key to know if programs are working and is essential to public health. Prevention is exemplified by rates of mortality caused by heart disease having declined over the last 40 years. The Dr. Dean Ornish Program for Revising Heart Disease and Cardiac Wellness Program of the Benson Henry Mind Body Institute were observed. Both studies revealed 80% of participants achieved their goal weight. Also, 70% lowered their cholesterol to proper levels, and cardiac risk factors improved significantly. Accessibility is up to the individual to avoid risk factors by behaving in a healthy manner, which is improved by public health initiatives, education, and other policies. Heart disease is a major concern, especially for low socioeconomic populations. When assessing a population, it is ethical to make sure privacy is not being violated. Any testing is done safely and with permission, mostly through observation. When assurance is being conducted, it needs to be done in a professional manner to encourage positive change and keep the public well informed. After determining risk factors, public health organizations like the CDC can track and investigate them. After defining the problem and determining potential corrective actions, public health organizations implement changes that will reduce the disparities associated with increased risk for heart disease. It has also been proven that smoking, lack of exercise, and stress are related to developing heart disease. In educating areas where low socioeconomic status is prevalent, public health organizations may be able to combat the increased risks for heart disease. Mobilizing community partnerships, which creates strong support networks, will provide people with access to information, education, and healthcare. Policies need to be enforced to be effective. Linking people to services is necessary for positive change. Reducing the affected has been successful through public health services, assessing the situation, making policies, and ensuring that programs are well working and sustainable. Here is a list of the resources that we have collected and presenting this for you today.